in the gut, what it does, it suppresses the hunger hormones called ghrelin, and it increases the satiety hormones. And in the brain, we have receptors in the hedonistic eating area where we eat more for our reward or for pleasure or anticipation of our reward. And it blocks this reward response from certain food that has a reward in our brain, either sugar, salt, or fried high-fat food. When you go on a GLP-1, you're going to get full with a third or half of what you normally would eat. It blocks that reward response.
Dr. Salas Whalen, it is such an incredible pleasure to be here with you again. First time was in Dubai where I interviewed you on stage. So I feel like we got our practice session in. And now we're doing it for the Extend podcast. Thank you.
I love it. I love part 2.
Yes. Dr. Salas Whalen is a triple board certified doctor. You are board certified in obesity medicine and endocrinology. And there is no more perfect person to talk about all of the science around GLP-1s than you. I mean, you've seen it from every angle for years, right?
I started prescribing it back in 2010 when I finished my training. And I couldn't wait to get out of training and start prescribing this medication because I work in a hospital. Yeah. And, we don't use medications that are new or expensive. Right. But as soon as I stepped out of the teaching hospital, I started prescribing it.
Yeah, and changed so many lives in the meanwhile, learned so much.
Exactly. I mean, it was something different of what we've been doing forever and ever, right? It was like the first different option that we had in decades for diabetes and for weight loss.
Yeah, it's so true. And, and I want to talk about both diabetes and weight loss today, but I was involved from the surgical side of things where the only solution people had that were morbidly obese was a gastric bypass procedure. And these procedures were big. They had a lot of complications. Even though the procedure, innovated as laparoscopic surgery, doing surgery with cameras, still people had a lot of complications, a lot of problems. It's a big surgery to, remove a piece of your stomach or reroute your intestines.
Yeah.
And I can't imagine anyone's even still doing obesity surgery anymore.
And what I think about that time is that many of those patients were not follow-up.
Right.
It was the surgery was done and then maybe seen 1 or 2 times and then lost to follow-up or left for the primary care to follow treatment. And what I think is, wow, how many patients did we actually worsen their metabolism by all the muscle loss that was happening, but we were not aware because we were not following the patient. We didn't know.
Yeah, it's so many people who jumped into the surgery and did it without any education about how their lifestyle needed to change. And you're right. I mean, there's so many post-bariatric surgery patients out there that have basically wasted away all of their muscle because not only did they stop eating just food in general, they really stopped eating protein, and that's what causes all the muscle wasting. And, I think so many things were done incorrectly for so long. You and I were talking a little bit earlier on your book, which is basically the guide now to doing GLP-1s. I mean, I think anyone, if you're going to do a GLP-1, you must read Weightless. It is an incredible book that you put together after decades of experience with GLP-1s on all the different considerations there are out there.
Definitely. Yeah. I mean, this is my gift to all those patients that we gaslighted for decades, many of them, right? I actually started my book with an apology letter to patients and to people out there that struggle with their weight, and we gaslighted it. And not to play Dr. Devil's advocate, but that's what we knew also as a medical profession. That's the only thing we knew was to tell patients eat less and exercise more. We weren't aware, we weren't taught. I learned everything that I know now, more, not even in my endocrinology fellowship. It was more preparing for my obesity boards and through my patients. So there's a big disconnect of what was really happening in the patient when they left our office to what we thought that it was not happening, right?
Yeah. So can we dive into that a little bit? Why did eat less, exercise more not work?
Because that is not what causes obesity, we know now. And that is not what would complicate somebody to lose weight or be predisposed to gain weight if you're not exercising or not eating less. That is one part of the causes of obesity and weight gain, but it's not the only one. And because that's the only one we knew and we thought we thought that the patient can control, that's where we concentrated most of our efforts. But now science has showed us that it's not a lifestyle problem. It's not the willpower of the patient. There's so many factors that go beyond even when the patient was born. Right? So the sole responsibility was put on the patient, and those efforts had to become so restrictive that they were not sustainable long term. So now we know that family history of obesity is one of the probably the most important risk factor for somebody to have obesity. So if your parents struggle with their weight, your grandparents struggle with their weight, there's a high likelihood that you will also struggle with your weight, like type 2 diabetes, right? We know that we are predisposed if some family members have type 2 diabetes. Then we go to environmental factors, food industry, industrialization, cities that don't promote walking, sedentarism, working from home, the food industry, highly processed food, endocrine disrupting chemicals, plastic, forever chemicals. All of that promote obesity. Then we have hormonal changes to a person's stages of life. Then we have aging that unfortunately we cannot do anything for aging, or maybe you are working on that sometime. But that also decreases your metabolism. You tend to lose lean muscle mass and more predisposed to gaining body fat. And then we also have transgenerational trauma. Trauma can also promote obesity in certain people. There's studies, and this is not just my opinion or my theory, there's studies that show that people that grew up in war or severe trauma, child abuse, sexual abuse, will be predisposed to having obesity.
Right. There's so many different facets of this that, we just never considered when we saw patients that were obese in clinical practice. And now to really dive into all of these, it's really helpful because not only are these reasons why people get obese, but these are also areas that we can put into place a treatment program to help reverse some of these factors, right? You can reverse your genetics, but you can moving forward, right? I mean, if you become a new person through either the use of GLP-1s or through any other methodology that you end up losing a lot of weight and you become, when I say a new person, a person who is no longer obese, that actually changes the methylation patterns of your genetics as passed on to your future generations.
Exactly. That's the key, right? Because when we talk about transgenerational obesity, we cannot blame their parents. We cannot blame the grandparents because they didn't have this information. But when I have a patient in my clinic and they're thinking about conception, I always tell them, either male or female, your weight pre-conception is going to determine the weight of your offspring. So this is where we can break that generational or transgenerational obesity starting now, because now we know.
It gives me chills to hear that. And this is all new science. It's the science of methylation patterns, which is the science of what genes are turned on and turned off. And you pass these along to your baby when you conceive the child.
Yes,
so
epigenetics.
Right. You hear a lot about Ozempic babies, right? People are getting pregnant more frequently because of the weight loss, but also their children arguably will have less chance of becoming obese.
And that's where we can change the course of this disease.
Exactly. It might take a couple of generations, but
exactly,
we can make it happen. And what has now become over a few generations the biggest health epidemic in the Western world, obesity, we can now have a pathway to reverse that.
And I don't think just with obesity. I think in the future, and again, it's going to take a few generations, we're going to have less type 2 diabetes to maybe in the future not having diabetes, right? We're going to have less incidence of certain types of cancers that are related with obesity, colon cancer, stomach cancer, pancreatic, breast, thyroid cancer. So we're going to have a decrease in many of the chronic complications that we see as a cause of obesity. I think that we built medical specialties based on the complications of obesity. So I think in the future, again, in the next generations, we may have more preventative medicine. We would truly be able to do preventative medicine.
Yeah, it's such an exciting time to live. Diabetes being one of the foundational risks for heart disease, Alzheimer's disease, even cancer. Once we can eliminate diabetes in society, you'll see a corresponding decrease in all of the chronic diseases, which is so exciting to see over the next few generations that happening.
Definitely, because what we know, the driver of most of the diseases that you just mentioned, cardiovascular disease, dementia, Alzheimer's, is either inflammation and hyperglycemia. Right. Both things they change our cells, as you mentioned. So improving those two, normalizing glycemia, decreasing insulin resistance, decreasing hyperinsulinemia, and decreasing visceral fat with weight loss, that's really the base of prevention.
Yes, yes. And so the critical hormone in this process is GLP-1. It and I want to talk about the mechanisms about how GLP-1 works. But first, before we talk about, the GLP-1 drugs, I think it's critical for people to understand that GLP-1 is a hormone in our body. And I'd love for you to take us through the science just quickly about where GLP-1 is made, how it works, and beyond weight loss, what are some of the things that GLP-1 can do in our body being a hormone?
Yeah. So the GLP-1 is a relatively new hormone. It was discovered by a female scientist, Dr.SvetlanaMoksov, here at Rockefeller Center in New York. And it was around 1982 that she discovered glucagon-like peptide 1 in the human gut. Posteriorly, but our own GLP-1 has a small defect, is that it's very short-lived. Once it's produced, it's broken down within 2 to 4 minutes in our system by an enzyme, the DPP-4 enzyme. Many pharmaceuticals tried to mimic this hormone, but they were running again in the same issue, that it was a short-lived effect. In 1992, Dr. John Eng, an endocrinologist at the VA hospital, isolated the first GLP-1 outside a human, and this was in the Gila monster in the southwestern lizard. There, what he found was a GLP-1 similar to our own, similar to human, but long-acting. So that was the base of what we have now, of what we know of their engineered version of our own GLP-1. And we know that GLP-1 in humans is made in the small intestine and also in the brain. But we have receptors all over our body for this hormone. So the effects, that's why we're knowing more and more effects, is because they're discovering more and more receptors through the body. But what in regards to hyperglycemia or diabetes and weight loss is through the pancreas, through the gut, and through the brain. So for diabetes, what it does when the glucose is elevated in somebody's blood above the normal threshold, it stimulates the pancreas to make more insulin. So that's the lower glucose effect is through the pancreas. But for appetite, we have receptors in our gut and in our brain. So we know our appetite is controlled both by brain and gut. And in the gut, what it does, it suppresses the hunger hormones called ghrelin, and it increases the satiety hormones. And in the brain, we have receptors in the hedonistic eating area, in the amygdala, where we eat more for our reward or for pleasure or anticipation of our reward. And it blocks this reward response from certain food. So if we think about it, what are the most common type of food that has a reward in our brain? And it's usually either sugar, salt, or fried high-fat food, right? Those are the most common that bring our reward. So when you go on a GLP-1, your satiety hormones go up, meaning that you're going to get full with a third or half of what you normally would eat. In between meals, your hunger hormones will be suppressed. And then in the brain, when you had the behavior for eating for a reward, either boredom, anxiety, binge eating, late night eating, even some drinks, alcohol, right? It blocks that reward response. So at the beginning, when you start, the behavior is still there. So you may go for that certain food or that drink, but it blocks the reward. So you don't have that dopamine release after you ate. Now, this doesn't mean that when you eat, you don't enjoy your food. When you eat, you still will enjoy your food. You'll get satisfied with smaller portion. It's more of the foods and beverages that will bring some sort of reward.
That's such a critical piece of knowledge, because it's not just about suppressing hunger. You're actually changing your relationship with food, the way your brain thinks about food. And, I think a lot of people, beyond being hungry, people eat when they're stressed. People eat when they feel depressed. People eat for all sorts of different reasons, even when they're not hungry. And with GLP-1s, what you really notice is that is also cut off, and it's through a different receptor in the brain at the amygdala level, which is completely different than creating hunger. Hunger is created through ghrelin and other mechanisms, but this is a different effect of GLP-1, which
Yeah.
is so critical for people to understand. I always tell people GLP-1 is a peptide hormone. It's not a drug. It's something that we normally make in our body. Yes, and to your point, we've been able to isolate it now in the Gila monster and then understand how to make this thing more long-lasting so we can give it as a drug now. But our bodies have been making GLP-1 since the dawn of humanity.
Exactly.
Right.
Exactly. So they're not something new. It's a new discovery, but it's been in our body. We just didn't know what it was doing.
Right. And now, just to complete this topic is GLP-1 receptors are now being found on immune system cells, for example, right?
Exactly.
I mean, there's GLP-1 receptors throughout our entire body because, it has multiple effects beyond just this hunger pathway. Can you maybe give people a little bit of idea of the immune response to GLP-1s and how that can be helpful?
And this is one thing that I have my patients, when you put a patient on a GLP-1, many of them will come back in their first follow-up stating significant improvement in inflammation and feeling less swelling, even before significant weight loss starts to happen.
Wow.
So this could be two reasons. Number one is that even within the first week, you're going to decrease the consumption of pro-inflammatory foods, right? Because we're blocking that reward system. Right. So those foods that were pro-inflammatory, you're not going to crave them. And then we cut by half the normal amount of food that you're going to consume.
Right.
So because of that, immediately patients feel a significant improvement just by, that tells you a lot of what foods we have, right? What type of foods that we eat, that also needs to be addressed.
Right. Yeah, I mean, the ultra-processed foods, that junk food that create a lot of the response, they're engineered to do that. A lot of the desire to eat more is what you cut off eating those
immediately.
Then, right. It's amazing. Like when I did the GLP-1s for about a year, and the first thing I did not want to eat was ultra-processed junk food. And I automatically wanted to eat more real food, which was an incredible change in perspective, and I realized I was way beyond just having the satiety, because when you feel satiated, it doesn't mean that you don't want junk food. You're still going to probably want junk food if that's more convenient, right? But you don't even want it anymore with the GLP-1.
Yeah, I have a lot of patients that say, now I'm craving chicken, now I'm craving fish. So they don't even recognize themselves, right?
Right, and they get pushed in the direction of wanting more real food. So this really changes your relationship with food, right?
And then real food, aka protein or macronutrients, also increases your satiety, right?
True.
So, and then it's like a really positive feedback that starts happening.
Yes.
So talking about inflammation, that's the immediate response. Okay. Then also, visceral fat is an active tissue. Fat is not a dead tissue. It's actually producing hormones. It's actually producing cytokines that are pro-inflammatory. So having high visceral fat puts the person in a chronic inflammatory state. What did COVID came and taught us? Because pre-COVID, there was a lot of question if really obesity caused inflammation. COVID came and made its case. Patients with obesity were the ones with higher mortality, the ones getting more severe disease, the ones with more frequent ICU intensive care visits, right? Because their body was in a chronic inflammation. And what does it mean to have chronic inflammation? It means that your immune system that is built to protect you from toxins, bacteria, virus, tumor cells was preoccupied fighting the chronic inflammation in fat that left the door open to come a virus out of nowhere and cause the disease, right? Yeah. So that's what chronic inflammation is. When you start on weight loss, when you start decreasing your visceral fat, inflammation decreases, right? So now we're talking about decrease of pro-inflammatory food, decrease of visceral fat, which is also inflammatory. That's where we're seeing the significant improvement. But we now know, research is showing us that there's also a direct, because those will be indirect effects of GLP-1 and inflammation, but there's also direct effect of inflammation. So GLP-1 is an anti-inflammatory hormone. So that's where you get this triple whammy in inflammation when somebody's using a GLP-1 medication. And I feel like in my case, GLP-1 is teaching us so much about our body, so much about the complexity of weight loss and the complexity of waking, that by being able to deconstruct it now, we'll be able to really target those things, right? It's new information that we're being proactive with it.
Yes, I completely agree. I want to highlight a personal story of myself. So I have an autoimmune disease that I've been suffering for the last 10, 15 years, and it went away completely when I lost a lot of weight. A couple years ago, the autoimmune symptoms started coming back despite my weight being normal. And it was really confusing to me. And I saw the rheumatologist, and they again wanted to put me on methotrexate, which is an immune suppressive medication. I said, no, I don't want to do that. And I was researching GLP-1s, talking about it a lot. And, I just read that there is some effect on people with autoimmune disease as well. So I put myself on a low dose of it, and lo and behold, the autoimmune system symptoms went away completely. And so, I don't know if you could speak to this or not, but it seems like there may be a direct effect on T cells and also on autoimmune disease. And is there a role for autoimmune patients? Maybe if you have, Hashimoto's, for example, is there some role there as well that we're discovering?
I think potentially there will be, right? But I think theirs will be a difference of the dosing of the medication, right? The dose that will not make patients lose weight if it's not being used for weight loss, right? To not suppress completely their nutrition. And also it should be a dose low enough that you don't lose weight, but high enough that it has some effect on your body. I think that's where the next studies will be done. Now, for that, we need healthy subjects to be tested with GLP-1, right? That's healthy subjects that don't have diabetes, pre-diabetes, and that they truly don't need weight loss. And for us to say that they don't truly need weight loss or they're healthy subjects, every subject should need to have a body composition, right? High muscle mass, high skeletal muscle mass, low percentage body fat, low visceral fat. That's a healthy metabolic subject. Use a GLP-1 there and see what is it that is truly improving. Because what we have now clinically, we can attribute it to the fat loss, right? And that could be most of the effect that we're seeing. So for really to say it has other effects that are independent of diet or weight loss, we need to test it in truly healthy subjects.
Makes total sense. And, when some research came out around GLP-1s and sleep apnea, for example, I always wondered, is that an effect of the weight loss or is that a direct effect somehow? And I think, to your point, that we don't know, right? Or is there anything new on sleep apnea?
All our studies that we have on GLP-1 are in patients with type 2 diabetes or patients with obesity.
Got it.
So all of those benefits that we're seeing, cardiovascular, sleep apnea, kidney function, it's in patients that because of their obesity, because of their hyperglycemia, this is most likely the cause of it, right? So we're seeing those effects because we're improving their glycemia and we're improving their weight. But again, we don't know if this will be the same in healthy subjects.
Yes.
And I see many people online are commenting, well, I don't need to lose weight and I feel great. Well, unless you show me a body composition that you had great muscle mass, low percentage body fat, low visceral fat, most likely the effects were because of improving those things.
Yeah, it makes total sense. And on that topic as well, neurodegenerative disease and Alzheimer's, there's a lot of research coming around with GLP-1s and Alzheimer's disease. Can you talk a tiny bit about that as well?
Yeah, I mean, because for dementia, what is it? It's inflammation, right?
Yes.
So it all goes back to inflammation. But also we have to have a conversation that in our body, we have our most potent anti-inflammatory organ.
What is that?
Muscle mass.
Yes.
Muscle, skeletal muscle mass. So we have three types of muscle in our body. Cardiac
please.
muscle, muscle in our gut, and then a skeletal muscle. The only one that we can work and build is a skeletal muscle. A skeletal muscle is an endocrine organ. It actually makes hormones. They're called myokines. And these hormones are the most anti-inflammatory hormone that we have in our body. Also, muscle consumes 80% of the glucose in your body. So it controls your glycemia. So if you have diabetes, hyperglycemia, building your muscle mass is one of the best things that you can do. Muscle also burns fat for energy. So you have a triple whammy there. Direct anti-inflammatory effect. It decreases, burns body fat for energy, and it decreases your glycemia. It improves hyperinsulinemia and insulin resistance. So we have something that is free, that we can work it out, and that is muscle mass, right? So a patient with a GLP-1 medication and also working on their muscle mass, that's ultimate health.
Ultimate health, absolutely.
Ultimate health.
Yeah, I always say your metabolism lives in your muscle. And I think to achieve ultimate health is not just about losing the fat.
It's not just the
building
GLP-1.
the skeletal muscle, right?
And that's why it's the importance of muscle loss, and that's going back to the bariatric surgery, right? Yes, patients lost 80, 100 pounds, but what percentage of that was muscle? We don't know because there was no follow-up. There was no studies. In patients with GLP-1, there are studies that showing patients can lose up to 30 to 40% of their muscle mass. But that's when it's done with the poor supervision. I say the efficacy and the safety of a GLP-1 is going to be directly proportional to the expertise of the provider on how they're going to guide you through this journey.
Absolutely. And so being on a GLP-1 is a journey. It is a journey that you need with an expert provider, medical provider that understands what are all the effects that GLP-1 are going to have on you, and how do we make this a successful journey in the right direction versus something that could be just like bariatric surgery, where it goes the exact wrong direction. You end up unhealthier despite the weight loss.
You end up what we call skinny fat or sarcopenic obesity, right? And not just sarcopenia. Sarcopenia is the loss of muscle mass. I see osteoporosis associated with sarcopenia, right? There's even osteosarcopenia as classified as a disease because the bone and muscle are a single unit, right? You need protein to make muscle protein synthesis, and you also need protein to build collagen for your bones, right? For the matrix of the bones. So that's why it's important to really follow and do your due diligence when you're going to pick a provider to give you a GLP-1. In my book, I talk about the green flags and red flags. But if your provider is not doing a body composition, either in their office or sending you to do one, or even in the first visit, telling you about strength training, telling you and explaining to you, not just telling you, but explaining to you the importance of the macronutrient, which is protein, and what you can do to increase the amount of protein when your appetite is going to be suppressed.
Yes, it's so critical. And those are red flags. If you're just getting a prescription for a GLP-1 and you're not getting a body composition and you're not getting recommendations for protein and strength training, those are big red flags, right? Because you will go down the wrong path. And there's a few other things that we need to talk about with a successful GLP-1 journey. It's funny because in our clinics at Next Health, we actually have patients sign a contract that they're going to do all of these things. And there's like 10 items that they have to do.
Definitely,
right?
You know,
accountability,
the patient that knows more does better.
Absolutely.
Because then they become part of the treatment, right? Then it's become more of a partnership, and now you just telling them, do this, do that, follow this. You came back, you failed, right? So patients need to have some accountability. And not because I want to talk a lot about my book, although I do, but this is also because why I wrote my book, because I know that the obesity medicine and the medications that we have are becoming more accessible, but we're not going to have the experienced providers for this supply. So in my book, I hope that patients are educated, and maybe they're not telling you to do a body composition, but you know that you need to do a body composition. I teach you how to read a body composition. I tell you how much protein you need to eat according to your body weight, according how much weight loss you need to do, right? So even if your provider is not recommending you, you can be doing the things on your own because you also have responsibility in this treatment plan.
Yeah, it's so true. And so as long as you have a roadmap and you follow the roadmap, even if you're getting your GLP-1s, like there's so many online services now just sending people GLP-1s after you fill out a questionnaire, you know. And it's the reality, unfortunately. I think the reality is people are going to get them no matter what. But the responsible way to do this, if you want to create health and not more disease, is to have that roadmap. And the roadmap, we talked about two things so far: strength. We talked about protein intake. Can you give us a little bit more on how to know how much protein intake you should be taking?
So ideally, our current dietary recommendations are like the minimum that you should aim for, right?
Right.
But what I've seen clinically by doing body compositions in all of my patients, it's around 1 gram per pound for ideal body weight, right? So when in your first visit, you can have this conversation regarding, based on your body composition, what is the recommended body weight, and then base the protein amount in a day from that. But for women, what I've seen is the sweet spot is anywhere from 90 to 100 grams of protein a day. Anything below that, I see muscle loss.
Okay, 90 to 100 for women. And for men?
It has to be higher, maybe 120 to 150.
Based on their ideal body weight.
Based on their ideal body
exactly.
weight. But I always like to not complicate a lot of things for my patients. So ballpark, if you're hitting around 100 grams as a woman, you're most likely not going to be losing significant amount of weight of muscle loss. And for men, anywhere around 150, 120 to 150.
Yeah. And just to make it real for people, I have these conversations a lot of how much protein you should take in. And unfortunately, I think people have a hard time understanding, like, we know the number. How do we translate that number to reality? And the reality is, the best way to do this, in my opinion, is what are the foods you like? Research the protein you get for that food.
Yeah.
So say you like salmon and fish. Find out, like, what is a portion of that salmon that's going to get you 40 grams of protein, for example. And then how much protein are you going to get every single day, and how are you going to make that happen?
Yeah.
I think that's super important, is you need to understand how you're going to make it happen. And it's not bad if you find supplements like whey protein, for example, to get the protein. It's just, you just got to do it, right?
When you're on a GLP-1, there's no way that you will be able to get 100 grams of protein exclusively from food. Yes, protein from food will always be best, right? Will be what's recommended, but in the moment that you're on a GLP-1, then everything changes. You're in a treatment, right? You are on a medication that is going to require that you supplement from other sources of protein to be able to ingest and take that amount of protein. So I like to break it really easy for my patients. And I said, okay, all you need to do in a day is 4 portions that each has 25 to 30 grams of protein. Because you're on a GLP-1, you're not going to be able to have 4 salmons a day or 2 steaks and 2 salmons. So 2 shakes of protein, of a grass-fed, third-party tested protein. Look, I've been drinking whey protein since my early 20s, and I just turned 50. So it's okay to supplement.
Happy birthday, by the way.
Thank you.
Is this yesterday or the day before, right?
Saturday.
Happy birthday.
2 days ago. And so 2 shakes, 2 meals. 3 shakes, 1 meal. 3 meals, 1. Not every day is going to be the same, but that's the way that you break it down. Because also another mistake that I see is people consume 50 grams in a meal and they count the 50. So to be clear, if you eat 50 grams of protein, you're not wasting 20 grams of protein.
Yeah.
We know that your body uses about 30 grams max for muscle protein synthesis. You're not wasting the other 20. It goes for collagen, elastin, for other bodily functions.
Sure.
But for muscle protein synthesis, you need to count 30 per serving or per portion. So 30, that's what I said, 25 to 30 in each meal 4 times a day.
Right. And just to kind of complete the topic about muscle building, I like to get my patients to buy like a bioimpedance scale that they can step on.
Exactly.
Right? And then you can like follow the trend line. It might not be perfectly matching up with your body scan, with the DEXA
The professional,
scan. But that's okay. At least you know what direction you're headed. And then you know whether you need to increase protein, increase strength training.
I always get that question, are they good? Are they real? I always say, it's going to be better than the regular scale.
Right.
And that's going to be the information that you will follow at home, right? But don't compare it to the professional version in the office or the DEXA scan or an MRI, right? But it's going to be better, more information than what you would get for a regular scale.
Yeah, the regular scale, in my opinion, is a piece of garbage.
Yeah,
no one should have a regular
nobody
scale.
Shouldn't, yeah.
Exactly.
Agree. Yeah, because it's telling us your weight, but it's including bone, it's including muscle, it's including your organs, waste, water. It's not telling us what we need to know.
Right, exactly.
For health.
Right, right. And so these bioimpedance scales, there's quite a few of them. You can buy them for like $25, $30 actually now online. And they work as far as directionality goes. And,
Exactly.
I think once a year, potentially getting a full DEXA scan is a good cadence. Do you agree with that? Or do you do it more often than
Well,
that?
I do have a impedance scale in my office, a
Oh,
professional
good.
grade, and I do it like every 8 to 12 weeks in my patients,
Amazing.
just more to follow muscle mass,
Right.
right? And then at the end for maintenance is also important.
Okay. I want to talk about a few more things that anyone on a GLP-1 should consider. What about micronutrient intake?
Definitely fiber is
Yeah.
important. And I think the two most important food groups that you can do while you're taking a GLP-1 is high protein and high fiber. Remember, protein gets converted into glucose too. Protein has carbs, less carbs than a carb itself, right? And less sugar grams than a carb itself. So for people to say, well, you're not consuming any carbs, you are consuming even when you're having protein, right? And then for fiber, you're going to do maybe some high fiber vegetables, right? Or starches. And that should be in a smaller amount. Starches can cause hyperinsulinemia and insulin resistance. But that's where you can get your fiber. What I saw is when I started recommending my patients protein, they were coming back with constipation because of the protein powder or because of the GLP-1 itself. I created my own protein that is whey plus fiber because I couldn't find one that had both things. So that's the only reason I'm doing a supplement, which I vow never to do supplements. But this is a real problem
It is.
that needed a solution for my patients of what I was seeing, right? Just combining, simple thing, right?
Fiber and
Combining the
protein.
fiber with the whey protein. But I'm not going to say my protein is the protein. You're not going to lose muscle with my protein. No, it's an option.
Yeah.
It's an option that is giving you also fiber. But so we have to get creative with our patients in order for them to meet all the nutrients required in a day.
Yeah, we do. And I think also, there's other pieces of the puzzle like vitamin D, for example, getting good omega fats. So I like to create a good supplement program for my patients on GLP-1s just because I know likely if they weren't getting it before and their vitamin D levels were low
Already
before,
low,
they're
yeah.
not going to get it now that they're on a GLP-1.
And also vitamin D is dosed per square meter in our body. So in patients with obesity or more weight, they require high amounts of vitamin D, right? But don't overdose vitamin D because I see kidney stones in my office so have a vitamin D level with your doctor and don't do more than 2 to 4,000 units a day. I think that's a safe amount. Unless you have vitamin deficiency, then you can get a prescription dose of vitamin D.
Got it. And the kind of vitamin D I like to recommend is D3K2, and that prevents some of the calcified stones and things from happening as well. Do you agree with that?
Yeah, definitely. You need vitamin K for sure.
Okay, I love it. Okay, let's talk about, this time that you're on GLP-1s, it really decreases that reward of eating, fatty foods and ultra processed and sugar. And it's really an incredible opportunity for people, right, to relearn how to have a productive relationship with food.
Yes.
And so I talk about this a lot. I'm like, look, we're going to do this, but you will gain weight back if you don't relearn how to eat, how to cook, what foods are nutritious for you. Do you have those conversations with your patients, and do you have some advice in your book around that?
Yeah, definitely. I think the biggest bet for somebody to be off the medication, if that's their personal choice, obesity is a chronic disease, right, for many. So it may be a chronic treatment, as many chronic diseases out there. But maintaining muscle is your biggest bet to be able to stay off the medication.
Right.
Or for my patients is to require the lowest dose for maintenance.
Right.
But if you lost all your muscle and you didn't regain your muscle, even to bring you down from high doses, it's going to be complicated.
Yeah.
So, and what happens when you build muscle? You need to eat protein. You need to exercise to maintain the muscle. So it becomes like a part of it. Just to maintain muscle is a lifestyle, is a discipline.
Yes.
So the patients that are able to do that, and the interesting and beautiful thing that I see in my patients is once they start forgetting about the number in the scale and they start coming every visit and like, how did I do on my muscle? Something happens. They start feeling strong and they never wanna let that go. It's once you feel strong and lean and fit and you're like, oh, I did this. I can pick up this. I can do that. When you see what your body can do because of the strength, it becomes almost like an addiction, right? And I don't want to say in a
You
negative
see the
way, but
patients like they flip a switch.
it's a switch.
Yeah, they
It
go
is
from
a
like being an
switch.
obese person to a healthy person,
Or
right?
coming for something external, right? Something physical. I want to fit in this dress. I want to be that size when I was in my 20s. Once it becomes something internal and they start eating healthy and they crave healthy food and they're not eating because of anxiety and boredom and depression, that they have control of it, it changes everything, right? So it becomes almost automated. So that's why many people that say, well, I'm afraid I'm afraid to go on it because I don't want to be on it long term. I tell them, don't prive yourself from the opportunity just because you're afraid of what's going to happen after, because that almost takes care of itself down the journey. That is if you're having the good advice and being guided the right way.
Yeah, if you do the journey right, a lot of the negative things that people talk about and publicize in the media, social media, very unlikely is going to happen.
Very seldom.
Another big thing that people talk about all the time is like Ozempic face or Ozempic butt. And that's also very easily mitigated by protein, building collagen, right?
Exactly.
And also like not losing the weight too fast. A lot of this happens when people start losing 3-4 pounds a week.
Exactly.
Right?
So we can talk about Ozempic baldness, right?
Yes.
Because that's another complaint, hair loss. If you're losing hair, you're losing muscle. If you're losing muscle, you're going to lose hair because it all comes from protein. You need protein to make collagen, as you mentioned, elastin, and for the hair cycle to continue to be healthy, right? So definitely all can be prevented with the right advice in nutrition.
Exactly. What rate of weight loss do you like to see with your patients?
I like 0.5 pound to 1 pound per week. That's
Totally
what I've
agreed.
seen clinically with body compositions on every visit that is very minimal muscle loss. And in some cases, muscle gain.
Yes.
So 0.5 pound to 1 pound, you will prevent muscle loss, you will prevent hair loss, Ozempic face, Ozempic butt, Ozempic everything, right? So that's how you prevent and you get to the end in your best possible health.
Agreed. Completely agreed. Now, let's also talk a little bit about the dosing, because I feel that there's a lot of talk about gastroparesis. There's a lot of talk about gastroparesis, for those of you who don't know, is when your stomach just stops working. In my experience, in the emergency room doctors I talk to when patients come in with like severe gastroparesis, almost always the case is that they went from a low dose to the highest dose faster than they were supposed to, and they've been on a high dose for a very long time. Is that kind of what you're seeing?
Yeah, I agree. I mean, each dose, and I think, again, this is the expertise of who's guiding you in the medication.
Yeah.
I see cases as new patients that come and their provider was going up every month on the dose. Even they were not tolerating their current dose, even though it was still working, even though they were still losing weight, right? They just, because of the availability of going or not knowing the medication itself, they go up every dose. So that's a big mistake.
And you know why they were doing that too, and a lot of patients want to do this, is because
Rapid
the way
weight
that
loss.
was that
Because of rapid weight loss.
Yeah, rapid weight loss. And the way the companies had it set up was that no matter what dose you're taking, it's the same cost. So people thought they were getting more for their money.
Exactly.
And right, exactly. So they got basically too much in a rush to lose the weight, and they feel like, I'm paying this much anyway, let's just keep going higher dose. And then they started getting all these complications.
Or the patients pressuring doctors also, right? That can be the case. I'm not losing enough weight. My friend is losing 5 pounds in a week. I need to be more. And then if you don't know, if you're not sure of how to prescribe this medication or the effects of this medication, many times we feel pressure, and some providers may agree with the patient and say, okay, I'm going to go up, right? So it could go either way, but I've never seen gastroparesis in my clinic.
Neither have I.
I've seen 2 cases of gastroparesis, and that's were on patients doing plant-based diets because of the high fiber and the type of food that they were consuming. But due to GLP-1 medication, I've never had personally a case of my patients, and I've been prescribing it for over 15 years.
Yeah, you have the most experience of anybody that I know. On the dosing, again, just so people can hear it, the way I like to do it is once they get you to a dose that you're losing a pound a week, we don't increase a dose anymore. Is that fair to you?
Exactly.
Okay. And I have patients that are on the lowest dose and they're losing a pound a week, and that's fantastic.
I've seen patients on tirzepatide, which is Mounjaro, and Zepbound, 2.5 milligram, which is the first dose. I've seen them lose 30, 40 pounds.
Yeah.
I've had patients that I've never had to go up on their dose, right? And some patients I do. I like to say that each dose has an expiration date of around 3 months, but not everybody, especially with tirzepatide, because the first dose is strong for many patients.
Yeah, I agree. Yeah, and if you could stay on the lowest dose possible, in fact, I don't even go up on the dosing anymore unless they're not losing weight. If they're losing weight, you're on a good dose. You know?
Also, if you're losing significant weight on the lowest dose, it means that there may be a chance that you may not need the medication, right?
Exactly.
But if we have to maximize the medication, then there's likelihood that you're going to need some dose long term.
Right. I'd like to talk about also, while you're on the GLP-1s, it's also a good time to get your gut healthy again, right? And I feel like a lot of people are constantly assaulting their gut with ultra-processed food and sodas and sugar,
salt.
right? And so, your gut bacteria are not healthy. And so you can use this also as an opportunity to get your gut healthy again, which can then lead to the production of bacterial species in your gut that actually benefit you to lose more weight as well, right? Can you talk a little bit about that?
Yeah, we know the microbiome, there's certain bacteria that lives in your gut that also can promote obesity and weight gain, right? So as you mentioned, there's a lot of stressors that we put in our gut, stress, inflammation, our diet. And once that's reversed, because your sleep is going to improve, the quality of the food that you're going to eat is going to improve, inflammation is going to decrease. So your microbiome is also going to regenerate itself to the healthy gut bacteria, because we need the gut bacteria.
Right.
So yeah, again, we're seeing improvement in many aspects beyond, but it all has to do of the type of food that we're doing or the lifestyle that we have too, right?
Absolutely. And I think, adding soluble fibers to feed your gut bacteria, some fermentable fibers as well, can really be helpful to get the gut bacteria to regenerate those critical keystone species like Akkermansia we talk about. That could be very helpful too.
And I think one misconception that I would like to clarify is that I see people get confused, and rightfully so. They say, well, if first you say that it's not eating less, that is not working for weight loss, but GLP-1 makes you eat less. So what's the difference there, right? I mean, it's just decreasing eating. But the difference is when we use a GLP-1, and that's why we have to remember it's a medication, it's a medical treatment.
Yes.
It's not an over-the-counter supplement that everybody's going to benefit from it. GLP-1 are beneficial for those that, because of epigenetics, because of their hormones, because of their age, the transgenerational trauma, it goes above their control, right? And that's what the food noise that comes in for people that are always ruminating around food or thinking constantly about food. This is the best effect that GLP-1 is going to have, right? So it goes beyond the just eating less, is when it's out of the control of somebody because of their genes, food, environment, hormones. That's where the GLP-1 is helpful. Yes, they're going to eat less, but for those patients, many of them don't have the ability to eat that amount of food or that type of food.
Yeah, that's so true. Another thing I want to touch on is another topic I want to touch on is the whole topic of the psychosocial implications of weight loss. So, about 15 years ago, I was on the Dr. Phil show here in Hollywood, and I was on there because I had a patient who had lost a lot of weight with gastric bypass surgery, and she had a tremendous amount of skin removal, which I had performed on her, face, stomach, breasts, everywhere. And this made her a completely new person. And because she had a renewed sense of confidence, it caused family issues between her and her husband, And so, obviously that's what Dr. Phil does. He breaks down those types of situations for people. But I think it's a real issue. And I think people go into taking the GLP-1 without being prepared about the potential social implications and psychological implications on yourself of having massive weight loss. So can we talk about that?
Yeah, and that's truly a disservice that we're doing our patients with weight loss, is not giving them the tools of what's going to happen once they lose the weight, right? as doctors, we've been concentrating decades on a number, on getting a patient to lose the pounds, to get them to a number, and then, because as doctors, that's what we knew, right?
Yes.
And mental health was not really a part of health until in the most recent years. Right now, we know that mental health is important. So patients that are losing significant amount of weight, there's a lot of changes that are going to happen. And not only that, many patients, when they come to me, and for many patients, I'm their last stop, right?
Yeah.
They have years behind them trying to lose weight, going to doctors, doing diets, exercise program, going to fat camps. Many patients have decades of trauma with them, right? We're not doing anything about that. We're not even acknowledging for many patients, right? So what I've seen in my patients is if I see them in midlife and they're starting with obesity early in childhood, they have trauma from their parents, their doctors, their bullying in school, or if they had sexual abuse, or it's so heavy that we're not giving them the tools for that. And what I'm seeing in my patients now is because and again, this is compared to bariatric surgery, that they were lost to follow up, right? So we didn't know what happened in their lives. We didn't know what they went through. We just assumed they lost the weight, they're happy, and they're healthy. Next. But what I'm seeing in my patients when they're coming back, and I'm seeing them for maintenance too, chronically, right? I'm learning a lot of the things that patients are telling me. One common thing is that patients tell me, well, I know I lost the weight, but this is not me. I still don't recognize myself, because for many patients, they're in this weight for the first time in their lives, in their adult life. For many patients, their spouses didn't meet them in this weight or in this new acquired health habits, right? So it's a big drastic change that is happening them psychologically. Physically, when the excess skin weight or more very sensitive to cold, that it almost becomes painful. So there are physical changes that we're not telling the patients to anticipate with the weight loss, but also personal things. Patients tell me, well, people treat me now better, and why are they treating me better now? I was the same person before, right? Or I see divorces in my office too, because also maybe your habits now will be completely different. And for many, I've had a couple that for them, their relationship was food. What they had in common was alcohol and food. So if the other person doesn't join in this journey, it becomes like you're living with a different person.
That's so true.
So many things that I foresee that we're going to need mental health journey supervision as well as the physical weight loss journey, right?
Absolutely. So is your advice for patients that are going to lose a significant amount of weight, see a therapist that could potentially, break this, right, as they're going through the journey?
Definitely.
Break it down for them?
I think to know what is it that they're, same as with your body composition, let's see what is it that you're carrying, and not just in weight, but also mentally and psychologically, right? Because that is going to change.
Absolutely. Absolutely. Such great advice. So, wow, this is a rapid fire, great advice on everything you need to think about when you're on a GLP-1. And, if you could break it down into just one piece of advice for someone that's thinking about a GLP-1, you mentioned the GPS philosophy. Can we talk about that?
Because I like to call it like a journey. It's a journey of a weight loss journey, or a health journey. What I designed here in my book, and it's very simple. I call it the GPS. It's like your GPS is your navigation. Same here with a GLP-1.
Right.
G is for GLP-1, P is for protein, and the S is for strength training. It's part of the same prescription. We cannot prescribe you protein. We cannot write a prescription of exercise. Actually, for some states we can for the gym. But we can, this GLP-1, protein, and strength training. Again, I like to simplify it for my patients, so as simple as that. But my biggest advice is don't overthink it, because what I see many patients is like, why I should have done this earlier.
Right.
But your biggest determinant of your success is who you pick to give you this doctor, or how well informed you're going to be.
Right.
And my book is going to give you even more information that probably your provider is going to give you.
Right. And I agree. I think, you got to pick a good provider, but you still need to self-educate yourself. You cannot shirk that responsibility. And so an informed patient is going to be the most successful one. Doesn't matter
Yes,
how good your doctor is, right? And
exactly.
so you must read Weightless if you're going to go on this journey. And I think it's a fantastic tool you put out there for people. And
Thank you.
I'm really excited about the future of humans, basically, to have these tools available now. But it's also it's with caution, that you need to do it with some caution and with the right professionals, and also educating yourself.
And I think people should not be afraid, or don't think that this is a pharmaceutical trick. I
Right.
mean, this is evolution. This is medicine. This is science, right? I see a lot of doctors prescribing metformin because it's been out since 1946. But we have to adapt to the changes, right? And embrace science. Otherwise, what we were doing is not giving the results that we were anticipating, right? So it's okay to be skeptical, but learn, educate. Don't let fear overcome the possibility of you improving your health.
Absolutely. Absolutely. And I think, there's so much out there on social of people being very negative about GLP-1s. And, it's not right for everybody. You're not saying everyone needs to be on a GLP-1, but don't rob yourself of the potential massive benefits
Yeah,
to not just your health, but the health of your children.
exactly.
If you haven't had kids yet, it can be a massive benefit. So I really appreciate you joining me on the Extend podcast today.
Thank you for having
Yes,
me.
of course. And the book is Weightless. Where can most people get the
So
book and learn more about you?
they can pre-order now at weightlessthebook.com. Also, Amazon, Target, any place that sells books, you can pre-order my book. It's going to be available December 30th in the U.S. and Canada, and January 1st, many other parts of the world.
Amazing. Congratulations.
Thank you.
Thank you for joining me.
Thank you.